Hello everyone, welcome to Chapter 6, Trauma and Stressor-Related Disorders. In this chapter, we will cover the definition of stress. We will cover the following disorders: adjustment disorder, acute stress disorder, post-traumatic stress disorder, and psychophysiological disorder. We will end, as usual, with a discussion about contemporary trends and future directions, followed by review and reflection. Looking at the definition of stress, we see that there is a key distinction that our text makes as it relates to the difference between stressors and stress. Stressors are the external events or situations that place physical or psychological demands on a person, and stress is the internal psychological or physiological response to a stressor. The key here is to remember that the experience of stress is that internal response to the external stressor. A quick and easy example of this would be that an external stressor might be studying for an exam that I have coming up. That would be the stressor, and the stress would be what I experience, the stress that I experience in preparing for that exam, and the internal response that I have to having to study to that exam, for that exam. Like I mentioned in the overview, we're going to look at adjustment disorder, acute stress disorder, and post-traumatic stress disorder. Other childhood trauma and stress disorders will be covered in our next chapter, Chapter 16. Adjustment disorders. Adjustment disorders are characterized by the exposure to a stressor of any type or severity, and adjustment disorder begins within 3 months of exposure to the stressor, but doesn't last any longer than 6 months after the stressor has ended. The prevalence rate of adjustment disorder ranges from 7 to 28%, and appears to be more common in women and higher income groups. Something to note about adjustment disorder is that it may be a common disorder that providers might use when there isn't another disorder that fits, but there needs to be a disorder in order to bill insurance. And I wonder if there is some correlation there with why we see the prevalence being a little bit, that it is a little bit more common in the higher income groups, that maybe those are individuals that are more likely to end up with that diagnosis, but not necessarily that they're more likely to experience a stressor or a concern with an adjustment disorder. With the diagnosis of adjustment disorder, the exposure to a stressor can be very, very broad. It can be a stressor of any type and of any level of severity. Examples of this might be divorce, separation, a financial crisis. It really can be anything that an individual would perceive as to be a stressor, and again, of any severity. It is at times difficult to diagnose due to the reaction needing to be considered out of proportion with what would typically be expected. And that's really difficult to measure at times, in that everybody's stress response and response to different stressors is going to be different in any given circumstance. But the key here with the adjustment disorder is to recognize that the symptoms begin within 3 months of that stressor and do not last longer than 6 months. Here you will see table 6.1. This will be a great table for you to reference back to as we move throughout these slides about the other disorders. Typical outcomes after exposure to traumatic incidents. Before we move into acute stress disorder and post-traumatic stress disorder, we are going to talk a little bit about these typical outcomes. Our text references 4 typical outcomes: resilience, recovery, delayed symptoms, and chronic symptoms. Resilience is relatively stable functioning and few symptoms resulting from a trauma. Recovery is initial distress with reduction in symptoms over time. And delayed symptoms are few initial symptoms followed by increasing symptoms over time. And then chronic symptoms are consistently high trauma-related symptoms that begin soon after the event occurred or the event was experienced. Here we will see our text table 6.2, undergraduates' lifetime exposure to traumatic events. Based on the statistics gathered by Fraser in 2009, we see that it is most common for undergraduates to experience an unexpected death of a close friend or loved one, and that women report this a little bit at a higher rate than men. Again, they're looking at the gender binary here for these statistics, and that what's reported as the least frequent exposure to a traumatic event is unwanted sexual contact. Again, there would be lots of factors to consider when looking at these statistics as far as what individuals feel comfortable reporting and how the researchers are gathering this information. Diagnosis of acute and post-traumatic stress disorders. Before we dive into these 2 disorders, I just want to make another comment about the last slide. You'll see that almost 50% of individuals reported that most common exposure to a traumatic event, followed by kind of decreasing. Some of them were about a third of individuals reporting, or a quarter, or a little bit less when we got to some of those bottom ones. But a key takeaway there for me, and I think for you guys, is to consider that during our undergraduate time and really during life in general, that it is common to be exposed to different stressors, and it is common to be exposed to a variety of different traumatic events, and that we can expect lots of different responses, and the most foremost common outcomes of experiencing a traumatic event would be resilience, recovery, delayed symptoms, or chronic symptoms. We're going to take a minute to look at the requirements for diagnosis for acute and post-traumatic stress disorder. For both of these disorders, you have to have a direct or indirect exposure to traumatic stressor involving actual or threatened death, serious injury, or sexual violence. You also have to have symptoms that fall into these 4 categories: intrusion, avoidance, negative alterations in mood or cognition, and arousal or reactivity, which sometimes we will refer to that reactivity as hypervigilance. And so the difference between acute stress disorder and post-traumatic stress disorder is the amount of time in which we experience these different symptoms. For acute stress disorder, we are going to see symptoms between the period of 3 days after the traumatic event or exposure to traumatic event to 1 month after the exposure to that trauma. And then it would shift into post-traumatic stress disorder if the symptoms are present and persist for at least 1 month. It is common for women to be diagnosed with post-traumatic stress disorder twice as frequently as men. There is a low prevalence of post-traumatic stress disorder in Asian Americans, and the lifetime prevalence for post-traumatic stress disorder for adults in the United States is about 8.7%. A variety of different types of traumatic events and stressors are associated with the diagnoses of acute stress disorder and post-traumatic stress disorder. Some common stressors or traumatic events that may be associated with these disorders are combat, sexual assaults, violent crime or domestic violence, sexual harassment, natural disasters, car accidents, or work-related accidents. There could be a variety of other types of traumatic events and stressors that also would fall into meeting diagnostic criteria for both of these disorders, but it is common to think about the military and that combat relation when we think about acute stress disorder and PTSD, post-traumatic stress disorder. However, it's much, much more broad than just that combat stress and trauma. The etiology of acute stress disorder and post-traumatic stress disorder. We are going to take a look at a variety of the factors and dimensions in some of the slides coming up. But this slide here, we're talking about the cause, right? Etiology, remember, is the cause of acute stress disorder and post-traumatic stress disorder. There are lots of factors associated with increased risk for these disorders. And this is something that we've been talking about throughout the semester, that the etiology of all of these disorders are so complex, and there are a lot of different factors that are interconnected and interplaying with each other. We may be at increased risk for these disorders if we have experienced more severe physical injuries, have had a stroke or brain injury, major burn injuries, rape or sexual assault, an intentional trauma, or we may have had a close relationship with the perpetrator. These are things that would have the potential to increase the risk of the trauma that we might experience. Lifetime prevalence of exposure to stressors by gender and PTSD. You'll see that we have another table from chapter 6 here, table 6.3, and it gives us some idea of lifetime prevalence and the risk factors associated with PTSD. Not going to dive too deep into that in this lecture, but go ahead and make sure you take a look at that table again, table 6.3 from our chapter. Next, we're going to look at the different dimensions as it relates to these diagnoses of acute stress disorder and post-traumatic stress disorder. As it relates to the biological dimension, we remember that our normal fear response is activated by the amygdala, and that the amygdala initiates that fear response, and it sends a signal to our sympathetic nervous system, which prepares us for fight, or freeze. Our text talks a little bit about fear extinction in this chapter as it relates to the biological dimension, and fear extinction is elimination of conditioned fear responses associated with a trauma. So we would see a decline in fear responses associated with trauma, and oftentimes individuals with trauma-related disorders show minimal fear extinction or decline in fear responses associated with that trauma, and this speaks to one of those symptom groups that we talked about earlier, the reactivity and hyperarousal. So because they experience minimal fear extinction, they experience more reactivity or hyperarousal. We talked a little bit again here about the genotypes and how having the two short alleles of the serotonin transporter gene does lead to a potential or risk for heightened anxiety reactions as it relates to PTSD. But again, some of the keys here from that biological dimension is, again, remembering that the amygdala activates our sympathetic nervous system for the fight, flight, and freeze response, and that is key in the ongoing trauma response that is triggered in these diagnoses of acute stress disorder and post-traumatic stress disorder. The psychological dimension, some risk factors, pre-existing conditions such as anxiety and depression, hostility and anger, would lead to increased risk for developing acute stress disorder and PTSD. And a key here for the social dimension is that social support can diminish PTSD symptoms. Social support is really a key protective factor when we experience stress and when we experience trauma, because we can feel safe in the context of those relationships. And so that social support and those healthy relationships is so important to healing and to not exacerbating potential symptoms related to both acute stress disorder and post-traumatic stress disorder. So if we have a lack of social support, that would be a risk factor for trauma survivors developing PTSD. Sociocultural dimension, ethnic differences, different exposure to previous trauma, cultural differences in responding to stress. Some other factors that we've talked about in class before is how racial trauma and how systemic racism might influence in this sociocultural dimension as far as increased risk factor for trauma-related disorders. We've talked a little bit already about how women are twice as likely as men to suffer from trauma-related disorders, and female police officers are less likely than civilian women to have PTSD symptoms. Looking at this from the multi-path model, we see these different dimensions, the biological, psychological, social, and sociocultural dimensions. We see some of the risk factors that contribute to the potential development and manifestation of post-traumatic stress disorder after experiencing a trauma. The next few slides, we're going to take a little bit to talk about treatment for these trauma-related disorders in adults. Medication can be used. Certain antidepressants show some effectiveness, but effective in fewer than 60% of individuals. Only about 20 to 30% of individuals show that full recovery. Some hypertension medication has shown to be effective, and the beta blocker may offer a little bit of a benefit as well. And that is related to how the trauma response has such a physiological response in our body when our fight, flight, or freeze response is activated by our amygdala. Psychotherapy is very effective in treating trauma. Some of the most common types of psychotherapy that would be used and that have been used for a long time would be prolonged exposure therapy and cognitive behavioral therapy. Prolonged exposure therapy involves exposure to trauma-related cues in increasing increments. So you would start with something maybe relatively small. Maybe it is just the therapist talking about an event instead of the individual talking about the event, and doing that in very small doses and gradually getting to other levels of exposure, of maybe having some in vivo exposure, even in going to a certain area or being in a location that reminds the individual of the trauma, and increasing that exposure and pairing that with some other therapy techniques in order to reduce the distressing symptoms that are associated with PTSD. Cognitive behavioral therapy is that cognitive and behavioral approach to decreasing those distressing symptoms and increasing functional capacity for the individual. There is a specific trauma-focused cognitive behavioral therapy, especially as it relates to working with adolescents with a history of trauma or who has experienced a significant trauma event and are experiencing symptoms of PTSD. Eye movement desensitization and reprocessing, so EMDR. There are lots of therapies coming out similar to EMDR, but a little bit different, that involve either eye movement or really some other kinds of connections. And so that's getting at the other parts of the brain, not just that prefrontal cortex, which sometimes is mainly targeted by CBT type therapies. And then polyvagal theory. I have a slide here. This next slide tells us a little bit about polyvagal theory. This is one of the really a contemporary trend and future direction of where trauma-informed treatment is going, and polyvagal theory is a key in how we treat individuals who have experienced trauma. We look at the window of tolerance. We look at how an individual might dysregulate outside of that window of tolerance, either into hypoarousal or hyperarousal, and have some really targeted therapeutic interventions depending on what this individual is presenting like. And we might get a chance to talk a little bit more about this in class, but if you are interested, I could also share more resources with you. The key here is just to know that this is a trend in where treatment is moving for psychotherapy. Psychological and medical connectedness. Psychological factors affecting medical conditions. Stress can cause a multitude of physiological, psychological, and social changes that influence health. There is the psychophysiological disorder, which is a physical disorder with a strong psychological basis or component. Some key medical conditions that might be influenced by a psychological factor might be having some actual tissue damage because of the stress, increasing severity or intensity of a disease process, physiological dysfunction, and both medical treatment and psychotherapy may be required to treat this type of disorder. And what we do know is that the body's reaction to long-lasting stress is associated with deterioration of the body. And so this makes a lot of sense that there can be worsening medical conditions as a result of the psychological factors related to trauma and stressors. Here we have a quick slide about coronary heart disease and atherosclerosis. Won't spend too much time on this slide, although I do think that it is really, really important to acknowledge the medical connection here and how stress can increase risk for coronary heart disease. And some other factors that increase risk for coronary heart disease are poor eating habits, obesity, lack of physical activity, high blood pressure, depression, and obviously stress and trauma. Have another slide here about blood pressure, but I'm not going to spend too much time on that in this lecture. And headaches, there are different types of headaches that can be related to stress and to trauma. Our text talks about migraine headaches, tension headaches, and cluster headaches. Stress creates a prolonged contraction of the scalp and neck muscles, which can result in vascular constriction and a steady pain. And that can contribute to these different types of headaches that you may experience as it relates to having high levels of stress. Asthma and asthma prevalence. You may remember from the video that we watched that Dr. Gabor Mate referenced the increasing prevalence of asthma, and that asthma is a chronic inflammatory disease of the lungs. Stress or other triggers can cause excessive mucus secretion and can contribute to both mild to severe symptoms of asthma. Stress in our immune system. Stress itself does not appear to directly cause infections. However, it does decrease our immune system's ability and efficiency in fighting potential infections, which does then result in increased risk and increased susceptibility to disease processes. Again, you will see that stress hormone here, that stress hormone cortisol that I've talked about, where we want to remember that hormone cortisol, that it has a key function in impairing the immune functioning and can result in, especially if we have high levels of chronic stress and high levels of cortisol released for long periods of time, we might see rapid weight gain, we might see high blood pressure, we might see changes in our skin, we might see increased mood swings, or even a change in sex drive and higher risk for both depression and anxiety with the higher levels of cortisol. Etiological influences. Again, we're looking here at potential causes. So we see the biological dimension that stressors can dysregulate our physiological processes in the brain and in our body. Early environmental influences might produce changes in our stress response systems, and brief exposure to stressors enhance our immune functioning, but that chronic exposure and the chronic release of that stress hormone cortisol becomes detrimental for us. Psychological dimension. Positive emotions help us regulate stress. Negative emotions can accentuate a stress response, and there are lots of other factors that play into this psychological dimension. And using the polyvagal theory language, a lot of this is about staying within our window of tolerance and being able to expand our window of tolerance to be able to better handle distressing, or to be able to more tolerate distressing situations. Looking at social dimension and sociocultural dimension, spend a bit of time here highlighting again from that social dimension that a key risk factor for adverse health outcomes as it relates to stress and trauma is a lack of social support. And for the sociocultural dimension, that exposure to racism and discrimination is a huge risk factor too, as it relates to kind of that chronic stress and the impact that the chronic stress and trauma has on our body. Treatment of stress-related disorders. When we're looking at stress-related disorders that might contribute to medical disorders, we would look at potentially doing relaxation training, biofeedback training, or cognitive behavioral therapy. Relaxation training would be maybe focusing on some affect regulation, some deep breathing, maybe progressive muscle relaxation. There could be lots of strategies implemented in relaxation training. And biofeedback training would be learning to voluntarily control our physiological process in order to improve physical or mental health. And we would do this by being connected to a device that would allow us to see our heart rate and our blood pressure in live time, and be able to see that as it relates to any behavior that we might be engaging in, any kind of therapeutic intervention we might be engaging in. Contemporary trends and future directions. Areas of research focus are moving toward looking at how positive emotions affect stress responses, the role of psychological factors on disease progression and prevention, and examining why gender and racial differences in stress responses exist. This idea of looking at the racial stress response is, I think, going to be even more, we're going to see that kind of exploding in research. And that role of the psychological factor, we were talking about that in class this week, that spending some more time there, because we see how important that is, those psychological, social, cultural factors, how important those factors are, and spending a lot more time there in research is another future trend that we're seeing. And now we've made it to the end of Chapter 6. We're at the reflection and review. Take a minute to consider these questions, jot some notes down if you'd like to, and I look forward to seeing you all back in class later this week.